transplants done even as short as 10 years ago were all matched transplants, either from a matched sibling donor or an unrelated matched donor. Around the turn of the millennium, it was just too toxic to do a transplant because of graft-versus-host disease. Baltimore is 63% African American and has one of the largest sickle cell populations in the country. And you can imagine the difficulty finding a match for sickle cell and other diseases that we transplant for African Americans. In fact, the data are that it's only about a 10% or less chance that an African American can find a matched sibling, an unaffected matched sibling donor, or a match unrelated donor in the registry. To serve our patients, we were one of the groups studying how to do mismatched transplants or partially matched transplants around that period of time. And we were lucky enough to figure it out. Actually, when Courtney was training at Hopkins was when we were doing a lot of this work. And we hit upon actually what turns out to be a pretty simple drug called post-transplant cyclophosphamide that allows now everybody to have a donor. And so the first thing I'll mention is that the vast majority of transplants we do at Hopkins are using half-matched donors or mismatched unrelated donors, and they're not matched sibling donors because it's just, as you heard from Courtney, only a 25% chance that you'll have a brother or a sister who's a complete match, and even less than that who is unaffected by sickle cell disease. It turns out that the results now with a half-matched donor are every bit as good as with a matched sibling donor, and believe it or not, our data at Hopkins would suggest that we may be seeing better outcomes with haploidentical donors. We can talk more about that for the reason that may be. You heard about the struggles that Craig Randall went through with graft-versus-host disease, and that was with a matched donor. I can tell you that we rarely see, Vanderbilt and the NIH will tell you the same thing now, graft-versus-host disease is a complication of transplants with the use of post-transplant Cy, even in haploidentical transplants. Most of our patients never see steroids, as you heard Craig got a lot of. Everybody that comes to Hopkins in need of a transplant now is able to have one. We also have no age limit. Up to this point, the oldest patient that we've transplanted with sickle cell anemia was 47. That patient's been out 10 years and is cured of their disease. Somebody asked about the cost of a transplant. The annual cost, the 1 year around a transplant, we've done this analysis at Hopkins, is about $175,000, which sounds like a lot of money, but for a lot of the new treatments and a lot of diseases, it's actually quite inexpensive. But even more importantly, almost every insurance company now covers transplants for sickle cell anemia. When we started our program in the about 2006, many didn't. We were lucky enough at Johns Hopkins to get most of our third-party payers on board, as well as Medicare and Medicaid. So what limited transplants around the country at many institutions was Medicare and Medicaid were hesitant to pay for it. We never had that problem in Baltimore, and it's one of the successes of us working with the government, I would tell you. And then I'll just finish with a few comments on long-term effects. I already told you that graft-versus-host disease is not common anymore, even with mismatched transplants. A lot of people have talked about fertility. At Hopkins, we've basically been developing the approach that we feel very comfortable with that allows us to do the transplant. We have just started looking at the long-term effects, and that's one of the things we're doing in the grant from the NIH that with Michael and Courtney. I can tell you that most of the patients maintain fertility. We don't know some don't. We don't know the exact number, and that's one of the things we're looking at. And most patients at about a year after transplant are able to stop all their medications associated with the transplant. So I just want to make a big point of how far we have come with curative therapy and bone marrow transplant for sickle cell anemia. And we only use non-myeloablative conditioning. Most people tolerate it very well. We do them as outpatients at Johns Hopkins. And most people are back to their normal life somewhere between 3 to 6 months after the transplant.